Good afternoon and welcome to today's CME activity. There is no commercial support. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity. If you're viewing online, I will list the evaluation link in the chat section. And if you're viewing after the fact, we will list the link into the description section of the video. It is my pleasure to introduce Dr. Supriya Manapalli, who is our Medical Director of Infection Prevention and Control.
Thank you, everyone. Welcome to the IT Grand Rounds. Our speakers today are Dani Rigal and Sandy Cutright. Dani grew up in Atlanta and attended East Tennessee State University for her undergrad and grad studies. She majored in epidemiology and focused her research on HIV and the lack of PrEP uptake in the southern states among Black and Hispanic MSM males. Dani relocated to Gainesville, Georgia after graduation and is currently working with District 2 Public Health in the HIV prevention program. While in her current position, she's been able to expand HIV testing services with community partners such as University of North Georgia and Good News Clinic. This expansion of services has allowed for the community to have accessibility testing among other prevention tools. Currently, she's managing the marketing campaign for PrEP within District 2 Public Health, which is scheduled to roll out March of 2024. Sandy graduated from Kennesaw State University in 2008 with a bachelor's degree in forensics and behavioral science. She has worked for the state of Georgia in various roles for 11 years and has served as a communicable disease specialist for over 5 years. In addition to her current position, Sandy is a certified mental health peer specialist and an addiction recovery empowerment specialist with the Georgia Mental Health Consumer Network. She is passionate about health education and advocates for reducing the stigma associated with STI testing and treatment. Please join me in welcoming Dani and Sandy.
Good afternoon, everyone. Thank you for being here, but most importantly, thank you for having us. My name is Dani, and as I was introduced, I actually work for the HIV Prevention Unit. I'm the HIV Prevention and PrEP Coordinator. We work out of District 2. For those of you who are not familiar, our District 2 is composed of 13 counties that are located in Northeast Georgia region. So we're composed of like maybe some metro when we're closer to Hall, but then definitely rural areas as we get outer in the outer counties. Because our Ryan White is located here in Hall County, I wanted to bring some statistical data that was gathered by AIDSview. As you can see, in 2021, the prevalence for HIV was 191 for every 100,000. Our link to care was 88.2%, received care 78.3%, and viral suppression 69.1%. Now, I feel these numbers are important because this is how we gather goals for HIV prevention. When we look at our prevalence, how we're doing with link to care, and what we're doing to be able to make sure that those clients are receiving care, we are able to create regular and accessible HIV testing. This testing also includes additional prevention tools such as condoms, PrEP, and education. And then, of course, our goal is to link all of those who are identified as positive within the first 30 days of diagnosis. In our clinical testing, we actually offer rapid and determined testing in all 13 health departments. So this could be done through going for an STD appointment. A person can also walk up and say, hey, I just want to get an HIV test done, and one will be performed. Those will be considered our clinical testing. Recently, we've partnered with University of North Georgia in the Gainesville and the Dahlonega campuses, which are within our district. And in their student health centers, they're also offering this type of testing, whether it be an STD panel or whether the person just wants to get the HIV test if they think they've been exposed. Our non-clinical testing is done through our outreach events. So every year we usually have awareness days that we try to bring to the community and offer that non-clinical testing. This could be done whether it is at a university campus through some events or sometimes shelters, or any partner really that just reaches out and having a health fair and they would like to have this type of screening, we go out as a unit and offer this type of testing. If we have a positive, we are able to do a determined rapid testing as well to make sure that the person is aware of what their actual status is. And at that moment, we start to offer our counseling as well. We created a QR code because we wanted people to be able to have access to our prevention tools, not just when we were out in the community or with community partners, but also in the privacy of their home. So by having this QR code posted in different places and bringing it to the events, we were able to get others to scan it, and in their free time, they go on our site. They are able to order free condoms, request PrEP appointments, an STD appointment, or a test HIV home kit, which is an oral quick. When we mail anything out, we make sure that it is completely private, discreet. We don't actually put our information on it. This way, if the person maybe is living with their parents, can just say, I don't know who sent this to me, and it allows them to have that kind of privacy. Also, we currently have 100 subscribers in this type of program that are condoms by mail. So the other component of our HIV prevention is linking those who have been identified having HIV into care. We have two categories, clients newly diagnosed. And newly diagnosed would be somebody who obviously was getting their diagnosis for the first time. The other category is clients previously diagnosed, but who knew the diagnosis and never got into care, or who have got into care and have fallen out of care. The reason I highlighted that second one is because it's actually more common to re-engage with those who had been previously diagnosed than we do in at least our area with new diagnosed. In our linkage interview, we have different sections that we're hitting, right? We want to know your demographics. From there, we talk about transmission. And I think this is so important because once the person is there, this allows us to understand, if they even understand themselves, how this was transmitted to them. And this is where we start having that conversation. You will be amazed of the rate of people that do not know how it was actually transmitted to them. And then it allows us to understand how we're able to educate them better and educate the public better as well. We also talk about partners, where we offer prevention services and counseling. We have a whole department that just does partner services. So that information that is given to us, we provide to that department to follow up with those partners. Another important part of this interview is those social barriers. So we know that if you've come out of care, there's a reason. This could be pill fatigue, could also be housing, transportation, stigma, or maybe lack of insurance. So by being able to speak about what kept you out of care, or what has happened, or what is your current situation, we're able to maybe create a plan for that person so that it doesn't happen again, or it keeps them from coming out of care. This is then communicated with the case manager, so she's able to follow up with any referrals that we need to do at the time. Support system is also very important. We want our patients to be able to have some form of support system, whether this be family or friends. And sometimes it's not even that. Sometimes it's just organizations that offer resources. We want them to be able to identify what that support system looks like, because then it would be easier for them to actually adhere to their care. Under our linkage, like I said, we do referrals for housing, transportation, food, HIV assistance, and care and medicine. Some patients do not have insurance, so we're able to get them into ADA, which provides treatment for HIV care and the cost of medications. Some patients, if they come during the enrollment period, we're able to get them on the private market insurance, and then we help them with the actual copay and the premium monthly. Our linkage interview also, once we're done, we are able to give them an appointment to our Living Bridge, which is our Ryan White here in Hall County. Also, the person has the ability to just pick an infectious disease doctor if they want, and then I will help them navigate through that process and, get that appointment. Counseling will include speaking, like I said earlier, partner services, prep for those partners who are there present after we test them, and then really promoting condoms, even if you get on medication and you become undetectable. When a person is on edge about getting into care, we do have a session of our linkage that's called ARTIS, which is Antiretroviral Treatment Access Study. This was created so that we are able to offer that client sessions where they would sit with us and we're able to maybe put together some objectives, identify barriers, and then how we can overcome that. Some clients, once the sessions are over, are willing to go into care. Some do not. And so then we just kind of keep the case open at that moment. Here is what that plan looks like. I know it's not that great, but as you can tell, we'll have the objective set out activity as to what will need to take place, what strengths they currently have going for them, what may be a barrier that can keep them to, get to that objective. And also having like maybe some target dates, right? That way they're looking forward to something and kind of working on that. And as always, the Department of Public Health is to prevent disease, injury, and disability, promote health and well-being, and prepare for and respond to disasters.
Good afternoon. I'm Sadie Cutright. And as Dani said earlier, thank you for so much for having us. And thank you for being here. All right, let's see. So I'm going to talk to you about syphilis. Syphilis has been called the great imitator. And the reason for that is the symptoms mimic a lot of other diseases, most commonly skin diseases because of the rash. Syphilis is spread during pregnancy, sometimes breastfeeding, skin-to-skin contact, and sexual contact. It can lie dormant in the body for years, and then it can wreak havoc. It affects your brain, organs, heart, can cause permanent vision and hearing loss. So, outside of public health, I had never, I'd only heard about syphilis in like history books, not health books. I didn't think it was as prevalent as it really is. And when I started working in public health in 2012, Georgia was second in the nation for syphilis. Now, 8 years later, it's more than 8. We're at number 19 in the nation. So we've done a lot better. Let's see. That's me. So what we do at public health, Dani was talking about the department that does partner services. That's our department. We do partner services. So when we get a notifiable disease in SENS, let's see. We're going to review the history of the patient to see if they have a previously treated case or if it's a new infection and they need to be brought in for treatment. And then we have to make sure that individuals receive appropriate treatment as well. So we also interview patients to determine the source and the spread and do partner services. Partner services consists of partner elicitation, which can sometimes be challenging. You have to identify the proper motivation for people to want to tell you that kind of sensitive information. And partner notification, which is confidentially contacting those partners and notifying them of an exposure and getting them in for testing and treatment, which is important for, disease intervention. Let's see. And this is the last 5 years. This is just in District 2, which is the 13 counties in the northeast corner of Georgia. So the lines for Hall County and the district overall are still on a steady incline, as you can see. But Habersham, and I just picked a couple of random counties in our district. Habersham, Stevens, and Franklin, as you can see, the numbers are going up. There was a little dip in 2020, I guess, because of COVID, but we've caught up and surpassed all of that. And I also looked at the data for age groups. Let's see. And Hall County is the largest county in our district of the 13. So for age groups, let's see. In the last 5 years, all are increasing, except, the over 50 crowd is still increasing, but not nearly as dramatic as the 20s. For 3 years straight, 30 to 39 was out in the lead, and then something happened, and the 20s have taken over. So, I mean, these numbers are alarming. And this is why, it's important for people to understand that syphilis isn't just in history books. It is a current problem today. Let's see. So for providers, there's 2 different testing algorithms. And either one is fine, but you do have to have 2 tests to make a syphilis diagnosis. You need a treponemal and a non-treponemal. The non-treponemal is going to be an RPR quantitative, and it'll have a titer with it. And the confirmatory test, there are a number of treponemal tests. There's the EIA, TPPA, FDA, Element OP. But you can't, the treponemal test does not differentiate between a previously treated infection and a new infection. That's where we have to look at their RPR titer. And that's how we monitor if treatment worked. And if, because once you've been treated, you can get syphilis again. But the confirmatory test or treponemal, once it's positive, it'll stay positive for life. Let's see. So titers. All right, this is where it gets complicated and fun for me. RPR titers. After treatment, so they're going to get a titer whenever they they get their first positive. Whatever that is, we look for a 4-fold, it's in the middle, example 2, a 4-fold decrease with treatment or a 4-fold increase to determine new infection. Once they're treated, we encourage them to come back to have a repeat RPR done in 6 months and 12 months so that we can, see where their titer is going. Let's see, for example, if someone starts at a 1 to 32 and then at their 12-month repeat RPR, they have, say, a 1 to 2. That's over a 4-fold decrease. Treatment was effective. If they come back in another year or 2 and their titer's gone up to a 1 to 8, we know that's a new infection. But if they never come back to get that repeat RPR, then it's going to look like their 1 to 32 went down to a 1 to 8 over the course of a few years. And that's a missed opportunity to retreat a new infection. And this is just some updated information on treatment. We treat with bicillin. And these, so the stages, there are 5 stages of syphilis. The first 3 can be treated with one dose, and the other 2 are treated with 3 doses. So it's important to have to stage it correctly, and so they can be treated correctly. Let's see. So the RPR, I didn't mention this in the last slide, but the RPR will go down on its own over time, like a number of years. And symptoms include, so the symptoms are only present the first 2 stages. The first symptom, or first stage, stage 1, primary syphilis, is going to be just a single painless ulcer, chancre, or lesion. It looks, like a number of other things, like ingrown hairs, one I saw recently. And that's going to last 4 to 6 weeks. The secondary stage is, manifests in a non-itchy rash. Looks like a number of other skin diseases, rosacea. And the rash can be on any part of the body. It could be generalized, but if you see a rash on the palm of your hands or the bottom of your patient's feet, then you definitely should get a syphilis test ordered with the RPR. And then once the RPR is positive, you have a treponemal test to follow up. So early latent, stage 3, can only be diagnosed if that patient has had a non-reactive or negative RPR or syphilis test within the last year. And if they don't have signs or symptoms and no, labs in the last year, we can't diagnose them with any of the first 3. And that in 2018, we added, there was late latent, which is also syphilis of unknown duration. We can't prove that they contracted it within the last year. And that is going to be treated with, you can't see it. The bicillin times 3 doses. They get 3 doses at 1-week intervals. So they have to come back for 3 weeks. The alternative for bicillin is doxycycline, depending on their stage, doxy for 14 days or 28 days if they're allergic to penicillin. Now for congenital syphilis or neurosyphilis, There's no alternative. It has to be penicillin. Oh, there's it. Signs and symptoms go away on their own. Yeah. And the grand finales, it used to be thought that syphilis or neurosyphilis would only occur 10 years later, but that is actually not true. I most often see neurosyphilis in the primary and secondary stages, which is the first 6 months of the disease. And that is treated with IV penicillin for 14 days, every 4 hours for 14 days. So it's pretty intense. We've also come to understand that ocular syphilis and otosyphilis, which affects the vision and hearing. So people will come in with blurry vision, vision loss, hearing loss. And if they also have a positive RPR or confirmatory test, then they need to be referred for further evaluation and a spinal fluid or lumbar puncture to do a VDRL CSF with the spinal fluid. If it is not treated in a timely manner, people can end up with permanent hearing and vision loss. Sometimes with treatment, it will come back slowly, but the quicker they can be, diagnosed, staged, and treated, the better chances are. So at the health department, we have a rapid syphilis test. It is a treponemal test. It looks for antibodies. We can do those in outreach settings. So if you know anybody that's having a health fair, we would love to join you and do some rapid syphilis tests. If that's positive, then, we would have them come in for an RPR blood draw. And we also just recently got home test kits. It's a 5-panel test kit. It tests for syphilis, HIV, chlamydia, gonorrhea, and trich. And we can send those to patients' houses, or they can pick them up at the health department. They would register their test online, take their own samples. It has detailed instructions on how to do that. And it comes with a pre-addressed, pre-postage mailing envelope for them to send that back, and then their results are available online. So we also have that. And a resource I didn't put up here that I do want to mention, just for patients, if you're seeing patients and they've got, a communicable disease, there's a website. It's tellyourpartner.org, and it confidentially notifies partners that they've been exposed, and it will encourage them, to go in and get treated. So on the treatment page, if you search for your zip code, the first 3 may not be the closest to that zip code. The first 3 are usually the same. It's like the state of Georgia, an at-home testing place, and I forgot what the third one is. But if you scroll down, it'll tell you where you can go close by to get a free test. So that's pretty important resource. Any questions?
Thank you. If you're viewing online and you'd like to ask a question for Dani or Sandy, please enter it into the chat and we'll ask for you. Do we have any questions or comments in the room?
I just want to mention one thing. Thank you, Dani and Sandy. Just a few things. Effective July 1st, 2023, Georgia law requires testing of all pregnant females at 28 to 32 weeks and at birth for both syphilis and HIV. So again, this reflects why, because of the increasing numbers. And our lab actually recently changed to the reverse testing algorithm. So we start off with a treponemal test and then follow up with an RPR and then the titer. So that's the testing that's offered through our lab now. One question for regarding PrEP. How do you guys make that easy for those who, for the follow-up care and also to make sure they can get the medications easily? Because the PrEP intake overall in US is only 30% of the qualifying individuals. So we have a lot of room to improve PrEP intake here locally as well. So can you share more about that?
Right. So recently we were given a grant from the state level called PrEP Promotion. And what that grant does, it allows us to hire a PrEP navigator. And the role of this person is to actually assist those who are at risk for HIV transmission to enroll into a PrEP clinic. This could be done at the Ryan White Clinic. We do offer PrEP in all our health departments as well. We use Cutright as our pharmacy so that they get their medications by mail. But also, if the person didn't want to do any of that, they still just wanted to go to their, other providers like MedLink. And so we would still link them to that type of care. How do we keep up with that? We actually do quarter reports that we turn in to the state, and we're able, at least internally, we're able to see who has stayed on PrEP and who has fallen out of care. Those are called Curalytics, and it's a report that is sent to us. Is it monthly, Krista? It's sent to us monthly, and then we put in those 3 quarters and report that back to the state. Since we've had PrEP, being fully accessible at all 13 health departments, we have only had one person that converted into being an HIV patient.
Hi, thank you for this talk. If we see patients in the outpatient setting who test positive for any STIs, what are our obligations to report to public health, and what are our obligations to inform or to look for partners and let partners know?
So I'll answer for the HIV part. I'll let Sandy. Yeah, HIV is a notifiable disease. We understand that there is a perception that when you have that blood drawn and then it's sent to the lab, that the lab is then notifying it on the SENS system. That doesn't always happen. So we really try to encourage all providers to please reach out to your local, district, which would be us. You can reach out to epidemiology, which would be Marie Brown. My information is also up there. Either of us would be good contacts for those kinds of cases, because then we're able, whether the person goes into care with us due to lack of resources or goes to care with a private provider, we still want to be able to have access to them so that we can guide them and then follow up with them in that sense. I hope that answers that.
Correct me if I'm wrong, Marie, but isn't there on our website, District 2 Public Health's website, a way to report disease and notifiable diseases?
So look, it goes to that.
Oh, she's going to bring you the mic.
Sorry, Marie, the people online can't hear you.
So like what Dani said, that report will go through our notifiable disease system, which is most likely SENS, the SENS system, but also reports can be made via fax, via phone call to our epidemiology department at District 2 Epidemiology Department for all notifiable diseases, including HIV and other STIs.
I also want to add to that sometimes I understand that patients get their tests done elsewhere that may be outside of our district area, and then they come up, to see their providers in this region. It's possible, and it has happened, where we lose contact because a patient got, let's say, tested in Ada, Atlanta, and so now is been picked up by a coordinator over there, but that communication never happened with this district, but the person actually lives within our area. So that's why we really want to bring awareness that, if you do know that the patient's coming to you and they recently got diagnosed, please let us know. If the person's coming to you and they were diagnosed out of state, please also let us know so that we can follow up with them, because sometimes those out of state is where they didn't get care there, and then they're here and they're not following up with any care either.
We would like to add that partner notification services, that's confidential. Partners will be notified of their exposure in a way that our investigation, we're identifying patients. So our main goal here is to get partners in, get them tested, and if a lab comes back positive, we're offering them treatment.
I will say that the IPC team has a data specialist, and that is her job. So any labs that is ran through our lab, in GPG, stuff like that, she does input that data into SENS, what they're talking about.
I know that the demographics have kind of evolved from what they originally were. Can you elucidate what they are here in District 2 and maybe the Atlanta area and the rest of Georgia compared to other areas?
For HIV?
Yes, for HIV. And
Right.
if it's any different for syphilis.
So to be honest, I really can't answer much on syphilis because I don't really specialize, so I'll let her answer that. But I can tell you that our number one transmission still is male to male sex, with our top two race being African American males and Hispanic males. Then from there, we have African American females, heterosexual sex, and Hispanic females. That kind of lines up a little bit with what we would see in DeKalb or Fulton or Clayton counties.
Syphilis rates are also higher among men who have sex with other men, but I don't as far as the demographics. Do you know, Marie? I don't have that data on me at this time, but I believe it's available on our website. It is. Or we can get that information.
Okay. For PrEP follow-up, do they need to have a visit with one of you each time to renew the prescription? Or how do you make it easy for them to seek the care and stay in the care when it comes to either lab testing or STI screening for the follow-up visits?
Right. So when we have a person who's interested in getting into our PrEP services, their first visit will consist of running different panels. And correct me if I'm wrong, their kidney and liver function, along with an STI panel. Once those come back, there is a 7 window where we're able to get the person prescribed, regardless of when they receive that medication, right? Then they have a follow-up at 3 months or 1 month, and then at a 3-month mark for them to keep coming back and testing. So we're definitely looking closely, as to how they're reacting to that medication and if what their risk is. They get counseled the whole way, and continue to encourage them that even though their partner may be undetectable and they're on PrEP, still, practice using condoms as well.
Do you guys also offer the injectable PrEP or just the oral medications?
So that gets a little tricky, right? We do offer it, but it would be only to those who have insurance, because we also offer PrEP to those who are uninsured. And we're not able to carry that cost for the uninsured. But for those who have insurance, we're able to get at least a prior authorization. Then it just kind of depends on whether the insurance wants to approve it or not. The person that can actually answer that better, because she does our prior auths, would be Carissa. But in that sense, yeah, we do offer Apergy.
I got a quick question for ladies of the night and also now men of the night or whatever. Do you offer condoms for free or anything, so they can
Right.
prevent?
So our QR code that I had on the presentation takes you to the link where you can actually request what type of condoms you would like based on your sexual presentation. Yeah. On your sexual preference, and we put those together and we send them out every month at no cost to the person. They can also walk into a health department, ask for them, we hand it to them. Ryan White clinics, we have them at the university. We have condom dispensers. We have a total of 72 condom dispensers through the university where we refill and put those condoms out there for them to take for free. But also if they don't want to take it because it might be in front of their friends, the QR code is in all of those dispensers. QR code.
And you can come to the health department and pick up, free condoms as well.
I think we send like a total of 60 per package per month.
100 subscribers.
So can you share anything regarding any work health department is doing with the whole opioid epidemic and the IV drug users who are also at risk of HIV transmission?
Right. So the only thing our district does not have is the syringe program. That's something we do not have in our district. It is in the surrounding districts though. But what we're trying to do is we're really trying to go out there in the community, trying to identify what that population looks like. Obviously, we have 13 counties to cover, so it is a very diverse population, different culture in each of those. One of the things that we're working on right now is that PrEP marketing campaign where it's kind of customized to each of those counties. That way there's a better, receptive feel from them. And kind of just, we're slowly going to roll it out to see how people feel about the conversation of PrEP. We also, when we have our testing done in our forms, there is a series of questions as of what their health has been for like the last 5 years. One of those questions is, have you been an intravenous drug user or have you had sex with someone who's an intravenous drug user? And that's how we're able to kind of pick up as to which counties are seeing more of those people.
Okay, I don't see any questions online. Oh, one more.
Anything to share about any other STIs the Work Health Department is doing other than HIV and STD? How do we do locally here, and any information to share?
So I will let Krista talk about our Express STI that we currently offer. She will have more knowledge on that.
Can you go to the stage, please? Thank you.
So I'm Krista Schaefer. I'm a nurse, HIV and PrEP supervisor for District 2. I was not expecting to talk, so I'm sorry. The question was about Express STI.
What other STIs?
Okay. So we do currently at all 13 of our clinics have a program that we do that's called Express STI, and that's where they can literally just walk into a clinic, any one of the 13 clinics, and get chlamydia, gonorrhea, HIV, and syphilis testing for $37 flat. That's it. They go in, they pay $37, they get all of that testing, they'll get the HIV results instantly. And the rest of them, they are told to call usually within 3 to 5 days afterwards to get the results. I think that's pretty
And we
much it.
still offer the at-home test kits, the 5-panel test kits that they can do at home. We can send those to their house for free.
Thank you guys for being here. I'm internal medicine resident. I have a question about, so you mentioned that a lot of patients around here are diagnosed with HIV, syphilis, but are never treated. Why do you guys think that is, especially when you just mentioned the cost? I don't know, maybe there's barriers to transportation, but why do you guys think they just didn't go through with treatment?
So our number one is housing, right? I'll give you an example. Someone comes out of incarceration. Now, while they were incarcerated, they were probably receiving medication for their HIV. But once they get released, in some cases, they'll receive like a month's supply with them. That coordinator then contacts us so that we can link them into care. But that person may actually not have any housing or transportation or a phone number for us to reach. So then we're just kind of like searching for you out there and kind of waiting for you to contact us. Medical care for their HIV does not become a priority anymore if you're experiencing housing issues. So what we're trying to combat that with is by having programs like HAPWA, which is a housing program for those who are living with HIV. However, that also comes with some barriers, right? If you got charged as a felon, some of these landlords may not want to receive any funding, whether we're going to pay for it or not, because you have this in your record. So then we have someone out there who, you know, we have the resource, but we can't give it to them because there's no actual landlords that will accept that. The other one is actually transportation, but we do offer transportation. But the downfall of that is if you live out in Towns County, I can't get you an Uber. I have gas cards, but if you don't know anybody, how are you going to come down here? That's about an hour and 40-minute drive. So this is kind of like the barriers that we see in the rural areas. One thing that we try to do once we identify those barriers is maybe assist them with relocating to Gainesville, where we have Uber and Lyft services. And then some housing, like some shelters as well.
Also, while I'm walking over, we had someone online that says the QR code is not working. So I'm not sure if you could, Marie, maybe you can email it to me so I can send out.
It might be cut off from the border on it. Yeah. Well, it's actually ours. We'll email it to you.
So do want to add to what Dani talked about, housing and transportation barriers. There are other social barriers, a lot to do with stigma. Most patients are resistant to seek care because they feel they will be judged. So our services from the STI standpoint, when we interview our patients, our case managers tend to be non-judgmental. We try to meet patients where they're at in that moment, provide services that gear towards the care that they need. We try to take into consideration people come from different backgrounds, and we respect that highly in the services that we will provide to our STI patients. So we also do field visits. So we go out to patients' homes. So in our STI program, where transportation in the HIV program, they provide transportation for patients to come out. We go out to patients' homes for our syphilis program. So if a patient is resistant to come out, the health department, our CDS workers, that's our communicable disease specialists, they will go out to patients' homes. We try to meet patients in the community at our health departments and do our best in making sure that these patients receive testing and treatment. We also do that. I talked about partner services. So where if patients are seen within the community, they may only get tested and treated, but there's nothing being done for their partners, and they may become infected again. So this group, this CDS group, they are responsible to do partner services. So once we have that information from our patients, if that information is provided by a doctor's office, we will be reaching out to partners also.
Excellent. Thank you. Okay. Comments or questions? One more comment.
Last comment, let me just say it. I do want to mention a few things. Recently in GPG Quality Committee, working with Alex Niben, Dr. Bailey, the family medicine team approved the best practice guideline for PrEP. So hopefully that will be shared soon with all the providers. And one humble request is that when we see patients in the office, not just based on our perception of their high-risk behavior, but everyone getting the detailed sexual history, social history, and seeing if they would be a candidate for PrEP is very, very important, and also screening for STIs, because as I mentioned, we have a long way to go in increasing the PrEP intake in the community. Thank you for doing this today.
You're welcome. I also wanted to say, if you have a patient who you are noticing that they're not adhering to their HIV care or their PrEP care, you can reach out to us and we will try to see if there's any way we can identify what those barriers are for them and then kind of help them get back on that track.
Thank you, ladies.
Thank you.